too much maybe for Switzerland today, but
Okay, I will start with the broadcast in 1 minute. And
so Francesco, just to briefly tell you again, I have to leave a bit earlier at the end. I have another meeting.
Yeah.
So
you have the Brazilian Congress, I know.
Yeah.
So that's why you are the first to speak.
Yeah. Thank you very much.
Yeah, no worry. My pleasure. And so after the feel free to leave me.
Okay. Ladies and gentlemen, good evening. I am Ala Al-Banasuri. I am the Chief of the Corneal and Refractive Surgery at the Tomography Hospital in Jeddah. And I have the pleasure and honor to moderate this symposium. And I'd like to take the opportunity to thank CSO, especially the R&D department in CSO, for making this gathering possible. And this is a great addition to the educational series that CSO have been doing for the last few months. And this evening we have a group of wonderful presenters. And without any due delay, we're going to start with the first presentation from Dr. Emilio Torres Neto. Emilio works at the University of Zurich. He's an accomplished cornea, cataract, and refractive surgeon. Emilio has lots of publications focused mainly on cornea, keratoconus, cross-linking, and biomechanical properties of the cornea. And Emilio is going to teach us the OCT-based corneal topography as a new era in diagnostic. Emilio, please.
Thank you, Ala, for the very kind introduction. Let me share my screen here. So can you see the screen right now?
Yeah, wonderful picture.
Okay, thank you very much. So first, I'd like to thank CSO for organizing this very interesting webinar. It's such a pleasure to participate with this great team. Thank you very much. So let's go to our topic, OCT-based corneal tomography, a new era in the diagnostics. So these images here show our current equipment at ELSA Institute here in Zurich to evaluate the anterior chamber. So we have a wide range of anterior segment tomography and other devices as well. But And although I don't have any commercial interest at all, I have to say that this new device, which we've had since last year, has really been a game changer for us in some cases. So this is a spectral domain OCT combined with placido disc topography. So we have here the two technologies working together. And of course, this brings the biggest additive benefit of the OCT here. And we all know for a long time, but here are some advantages of OCT technology. And I would say the main one would be the image quality. So when we see a OCT image, we can clearly see it is from OCT. We can clearly define this. So the quality is something that brings us attention. But especially for cornea, the analysis of structures that normally are deeper in the cornea used to be better seen or better measured with OCT. So we are also used to check the pachymetry or the demarcation line in cross-linking, for example. We usually measure it with OCT. So we can see deeper structures, and especially it is less affected by the scattering, so opacities are less affected. And finally, another, now not on this deeper on the corner, but on the surface, would be the epithelial map. So this is a quite new additive tool in refractive assessment, I would say. So from now on, I will show here some cases in which we used OCT and it was decisive. So instead of speaking, I will show you some cases we had. So this first case was a patient with keratoglobus. So he had a very intense protrusion, as you can see here. And there is not only a diffuse thinning, but also some opacities. And when we see the Scheimpflug images, these were on the right, on the left inferior inside, we can see how those opacities limit the ability to view the endothelial level or more posterior in the cornea. And of course, this limitation of Scheimpflug also reflects the ability that we have to estimate pachymetry or the thickness of the cornea. So you can see the thickness, corneal thickness profile here, quite homogeneous from the half inferior of the cornea, and we questioned if this was really the case of our patient. But then on the other hand, here we can see already measurements with OCT and placido technology, and that was much closer to what we found clinically. So the left inferior images show now the corneal thickness profile of this cornea, and basically these better results and these better measurements would be possible, or they are possible, due to an acquisition of images that have less noise than Scheimpflug. And here you can see very well how we see the back surface very clearly here. And of course, this information can be very important for many reasons, but in our case was important for surgical planning. So advanced cases where DALC also would be indicated, this image can help to program, to plan the surgery. But here in this specific case, we did a cross-linking with our SUP 400 protocol, and it was very useful to estimate the thickness pre-operatively correctly. And here is the pre-operative progression. So before cross-linking, just to illustrate this case, and a stability more than 2 years after individualized cross-linking. So this is not a subject, but just to show you how we used this technology in our favor to really see almost limbo to limbo, both sides with high resolution in a keratoglobus patient. A second case that that OCT provided us with a very interesting tool was regarding epithelial maps. So this is a case of map dot fingerprint dystrophy. You can see superior on the placido discs there are some irregularities. And if you notice the resolution, the image show very well the epithelial lesions. When we do it a bit closer, we can see even better. And now this is another interesting tool that MS39 brings us. It's what it call anamorphic images. So basically it makes the anterior surface straight, and we here can see the cornea in a way that we were not used to see, but we can see, of course, a very high resolution. If you note, we can see even the Bowman layer. So the Bowman layer are those two layers just above the endothelial. So these can be very helpful for identifying, for example, patients after PRK. So if you're not sure if the patient had or not PRK before, we could observe these two lines. So the presence of Bowman, of course, would say that the patient did not have PRK. But here, our patient, and again, we could see that the lesion of that patient were just at the endothelial. So this image brings us a new toy, let's say. And not just that, but also this steep area that the patient had coincides or there corresponds exactly where the epithelial thickening area was. So in this case, specifically, the epithelium was removed. This here was with alcohol. And then right after, a PTK of 15 micra was done. And here, just right after the surgery, you can see the epithelium was removed already, and we can see how the epithelial surface was improved, and this was reflected by the sagittal anterior topography, and this was just after the procedure. But perhaps this is one of the most interesting cases we had, as we could observe, which actually changed the treatment management because of the OCT technology. So a patient came with mixed astigmatism for refractive surgery. Here you can see the preoperative tomography. So she had mixed astigmatism, and that was ablation profile that was planned and performed. And the patient, the surgery had no issues. The post-op was unremarkable. But then a year later, the patient returned, and she was complaining about low visual acuity, and we could see here in the periphery the haze. So this is an OCT image. On the right corner, we can see the densitometry from a Scheimpflug device. And here again, the tool that MS39 provides us, we could see dotted in the yellow lines, the epithelium, and right above in the peripheral area where the ablation was performed, we could see there the haze. And this was a year after PRK, so on the left, the anterior curvature, and from Scheimpflug, and on the right is the densitometry. So you can see that exactly where the haze was, we had the flattening. And again, another Scheimpflug images now from Sirius. But for our surprise, I'll just come back here. You can see how Scheimpflug measure the topography. So it was a bit irregular at the center. But then for our surprise, this is the OCT-based topography. And what we could see was a very regular central astigmatism, actually. So we had now different technologies bring us different results. And in this specific case, we knew that for Scheimpflug, haze was or is has a limitation. So we consider this exam from OCT the real or the most close from what we thought. So this was the case where the OCT changed our management. Actually, there were two surgical options that we thought about, and those options were the dependent on the pattern of the ocular surface. So we would perform a PTK if we had a regular astigmatism or a regular topography, while we could have done a wave-guided PRK, for example, for irregular anterior surface. So this case, PTK was preferred from the reasons I told you, because we had a regular topography on OCT, and here in the post-op period, as you can see, the haze improved, and also visual acuity show us now a more regular surface. So this could be achieved, and this was an important case for us that we realized OCT can be very helpful. And lastly, here I will show two cases where the OCT can be very helpful in the screening of keratoconus. So here, a patient who came because he had had previous diagnosis of keratoconus for other colleague. So he came for a second option, and we observed a cornea that, although had the cornea had a loss of regularity. It also had reduced thickness. So if I'm not wrong, it was 480 micra here. And this image from Scheimpflug showing a bad D of 0.97. So normal, completely normal. And this is the fantastic high resolution image from the MS39 that we could see. And then we performed, in this case, the OCT with MS39. And our main purpose here was to check the epithelial map. And you can see here on the right corner, low, a completely normal epithelial map. Then now we had another parameter that we took also into account to reassure the patient that here that was probably not a keratoconus. So all the devices had the same answer. It's important just about the epithelial maps in OCT. Of course, it can be an additional tool to screen keratoconus, but it's just important to remember that screening is a method to identify the disease before it presents signs or any symptom or visual acuity changes. But this is not the same as diagnosis. So normally screening methods has a high negative predicted value. So when we see that it's normal, this would be probably the case. So that's why this case was very, that OCT with epithelial map was very helpful in this case. And finally, a curious case also regarding the use of epithelial map in keratoconus. So a patient with a topography, he had a very high asphericity, as you can see, minus 0.58 in Scheimpflug, and the bow tie was a bit truncated. There was a superior inferior around 1.5 diopters difference between the central area, and the patient had a completely abnormal bad D. So some would say that would be over 1.2 or 1.6, depending on the sensibility and the specificity. Here, the patient had 2.18, so completely abnormal. And also biomechanical parameters completely abnormal. So the patient had keratoconus from these devices. But then, from this perspective, I would say, but then with the epithelial thickness, we had a completely normal profile. This is the image from the patient. You can see the thickness very regular in the whole cornea. And just as an example, this is not the image from the patient, but in an advanced case of keratoconus, that's normally what, not necessarily advanced, but in keratoconus is that perspective we would see. So we can see the posterior flow changed, but also the epithelial changes. So the thinning on the apex of the cornea, as Dan Reisten described it as a Dunnet pattern. But here again, coming back to our patient, we did not find any of those patterns or signs in our patients. So the patient really had a normal epithelial map. So that case, especially after, if you, the other panelists could comment their opinion on this case, because I would like to learn actually, but that's what we call a low K keratoconus. So it would be a keratoconus, but with low K. And the interesting point here, the patient had a normal epithelial map. So we believe this case would also not be progressive. So here I'm saying something that is not consensus, because we don't have studies to prove that so far, but maybe epithelial map in future can give us a tip, let's say, if a keratoconus would be progressive or not. We can speak a bit of this later, but we always wanted a tool to in one visit bring this answer. And of course, if the cornea is changing, the likelihood of having an epithelial change would be higher. But here specifically, so we classify this as a low K keratoconus with a normal epithelial map. And but this shows exactly how the new technologies do not always agree from our perspective that we have nowadays. And of course, we have a lot to learn on this, but for sure, the epithelial map and the whole evaluation that the OCT technology can bring us together with the posterior float add a lot of information for us in this case. So as a final messages, the epithelial map is an important additive tool for keratoconus screening. As I said, screening is different from diagnosis. And the combination of a high resolution OCT and Placido technology may help us in the management, such as complications. As I show you, this is particularly helpful as well post cross-linking, because due to light scattering, the OCT it is very helpful to evaluate corners that have a slight or strong opacity in cross-linking patients. They normally present a haze post-operatively, so the pachymetry is better assessed with OCT. So thank you very much for your attention.
Excellent, Emilio. Thank you so much. That was great presentation as usual and as expected from you. Thank you so much. Now we have a question and answer box at the bottom of your screen. So if any one of the attendees wants to ask any question, you can just post it on the Q&A box in the bottom of your screen. Now, Emilio, I have a question for you. You showed very well the importance of combining the Placido and the OCT, which was actually a dream that came true by CSO. And now we know that many other companies are following in the same track, and we're going to see many of these combinations later on, but CSO already made a very long step ahead. So the question is, comparing to Scheimpflug, the Scheimpflug was the golden standard for the last, I would say, 10, 15 years, and we all used it, we all learned from it. How would you compare the Scheimpflug versus the OCT in, let's say, screening patients for refractive surgery?
Yes, it's a very, very good question, because we, as you said, Pentacan or Scheimpflug or other Scheimpflug devices were our gold standard for many time. What I said, here we have the luck of having all of the devices, so we are learning one from one and for the other on the same time, and both can have variations, both have advantages and disadvantages, but with OCT we can have something unique that we don't have with other technologies. so far, that is the epithelial map. So we can both access the posterior float, which in this case is more reliable because we can measure better the pachymetry, but also we have the epithelial map. So it is a very complete tool, I would say, for evaluating anterior segment, and especially if you deal with complications after refractive surgery and the management, or even for cross-linking practice where you have usually a lot of haze. This is very helpful because it brings us answers that with other technologies we wouldn't have.
And from your experience with the epithelial maps, can the epithelial map help you in diagnosing the stage of keratoconus, early versus moderate versus advanced? Is there a quantitative tool here?
Yeah, it's hard. I think we are learning a lot from this. We don't have the definitive answers because also epithelium has a lot of variability. So the ocular surface can bring different results. What we would like to see is a normal epithelial profile. So this would say us the cornea probably is not progressing, but as I said, this is a very controversial. When I just mentioned in the presentation, but a tool that everyone, I'm sure all of us would like to have, is a tool that when the patient comes from the first time on the office, that we could say to the patient, okay, you are progressing, okay, you are not progressing. And we don't have this tool so far. What we do right now is, okay, we ask for the patient, you come back in 3 months, 1 month, 6 months, depending on our assessment. And then the patient come for the second, third visit, and then we are able to say, okay, you don't have a progressive disease so far, or you do have. With epithelial map, I'm not saying this is true, or because we are just learning from this right now, but imagine that the cornea is changing. Some people, some colleagues are already trying to evaluate if these changes would reflect on the epithelium. I mean, if the epithelium is completely normal, probably this would say us that the disease is not progressing. But as I said, this is just a hypothesis and we need to prove this in the future. But at least we have a hope that someday we can have a tool, or we have already, who knows, to tell if a cornea is progressive or not based on only one assessment.
Yeah, excellent. So we have a question here on the question and answer box coming from Enrique de la Torre. The question says, as we all know, hardware is just a part of the device's usefulness. Can you please talk about software update in refractive surgery screening and keratoconus follow-up, in particular for the serious? Thank you. So the question basically says, can you talk a little bit about the updates in the software the screening for keratoconus?
Yeah, maybe this would be better answered by the CSO team. I would leave these questions for them.
Okay, we'll leave this question and answer it later in the webinar. Emilio, thank you so much. That was a great presentation. Now we're going to move to our next topic from Dr. Fabrizio Zeri. Fabrizio from the Bicocca University in Milan. I know he just arrived from Milan a few minutes ago. Fabrizio is an extensive researcher and he has too many publications on dry eye and contact lenses, especially quality of vision and different types of IOL. And Fabrizio is going to address the very important topic of enhancing tear film assessment. Fabrizio, please.
So thanks, Hela, for the really nice presentation, and thanks again to CSO for inviting me to this very interesting webinar with so good speakers. So I'm going to talk today about enhancing the tear film assessment by the dry eye report. There's disclosures. So these are the key points that I'm gonna touch. So the dry eye disease, just a few slides about the dry eye disease and the enhancing of the tear film assessment. And then I will move to the dry eye report. So let's start. Dry eye disease is an
can you please share your screen?
Oh, sure. Sorry, Alan.
We like to see you, but we also want to
see
you.
Sure. I made a mistake. Oh, great. So dry eye report. Great. Can you see it now?
Yes.
Okay, good. Sorry again. So, okay, so these are the key points that I'm going to touch. So the dry eye disease enhancing the tear film assessment and dry eye report. So let's start with the dry eye disease. Is something it has been considered a maze, like a puzzle for a long time. And it is still a maze, I think. And so it's a big issue. If you look at this statement, for example, we can understand how big is this, the dry eye disease. So basically it's a global problem. Every country is affected, and at least more than 300 million people worldwide are affected by the dry eye disease. And it's one of the most frequent causes why patients ask for a visit by ophthalmologists, optometrists all around the world. So I think it's an interesting topic also for refractive surgeon, contact lens practitioner, and so on. How big is the prevalence? If you look at the prevalence, it's not easy to answer to reply to answer to the figures of prevalence. Why? Basically, I think the most important things is the prevalence, because the prevalence is calculated in different way. So, for example, if you look at symptoms, if you look at or a physician diagnosis or the diagnosis criteria, I think the prevalence change, and the figures are amazing. The figures change from 5 to 50% of prevalence in the population. So it's a very big gap. It's a very big figure. So how we can assess the dry eye disease? Basically, we can move with questionnaire or Scheimpflug test, or for example, tear meniscus age, or we can look at breakup time in several ways. We can measure osmolarity. We can measure, for example, the staining with different stains, like such as, for example, fluorescein or lissamine green, or we can look at the meibomian gland. Clearly, it's not easy to go around this kind of test, because there is no an available gold standard. Clearly, if we look at, for example, this the whole typhus deuce from typhus, we can see that the sensitivity and specificity of different tests is different. And the reason why they are so different is because there is a certain overlap between normal and dry population. So if the distribution of the dry eye and normal population is overlapped, clearly, if we put a cutoff in some way, we will get a false negative percentage of people, but also true positive, but also true negative and false positive. So, but if we shift, for example, the cutoff clearly, because the two distribution are overlapped, we can get a different amount of false negative or true positive, for example. So let's have a look at the definition of the dry eye disease. We know that has been changed from typhus, that is one of the most important reference group of researchers, scientists, clinicians. And for example, if you read the definition, the dry eye now is defined as a multifactorial disease of the ocular surface characterized by the loss of homeostasis of the tear film, with ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage play an extra methodological rules. So clearly, if we want to check, if you want to diagnose the dry eye disease, we have to look all these aspects of dry eye definition. I think this is very interesting graph, so figure proposed by these two, in which we can move around the diagnosis of dry eye disease in different way. So they highlight the fact that if you want to diagnose the dry eye disease, you have to look at symptomatology here, and we can use different tests, and the most important in terms of evidence-based are the DQ5 and the OSD as well. But also we have to measure homeostasis markers like a non-invasive breakup time, osmolarity, and ocular surface staining. And if you want to get information about the subtype classification of dry eye disease, we should look around the evaporative dry, but also dry eye that is linked to aqueous deficiency. So if you want to perform the best assessment, you have to look according to the dry eye, the TIFOS 2, all these aspects. But if you want to move forward and enhance the dry eye assessment, maybe we should also more than covering different aspects, we should also look at a different approach to the tier assessment. For example, a qualitative assessment, I think is worse than a quantitative assessment that can provide us numbers, figures that we compare with, for example, a distribution values that we can, so normative data. But also the non-invasiveness of technique is really important, as we are gonna see in a while. Also, we should move towards tests that are clinically performable, and so we should use something that can be used in a clinical setting. And finally, we should use something that is automated instead of using something that is linked strongly to the experience of the clinicians, for example. This is the reason why lots of manufacturers of instruments provided such as some devices to try to put together all these things. One of these devices is the dry eye report. Clearly, we have in the dry eye report from CSO, we have an hardware. Usually, is a placido-disc-based instrument, so can be different. They have different placido-based instrument, but they work all together on the same platform that we call the dry eye report. So the dry eye report is a collection of standalone examination, and that can allow us to perform different tests. Clearly, also we apart of placido-disc-based topography or topographer, we have an infrared light camera that, for example, can allow us to perform a mammography, and also a moving lens able to vary the depths, so the field, the focus and the field of the acquisition. Clearly, all is linked to a software that can allow us to perform different specific tests. For example, these are the tests available in the system, so in the dry eye report. So we have clearly an ocular surface disease index, so the OSD implemented in the software, but also a device that for the ocular redness analysis, another device for meibomian gland analysis, another one for tear meniscus analysis for the tear meniscus 8 measurement, and also devices that to measure the breakup time in a non-invasive way, and also a device, more than a device, a way to report the osmolarity that is performed with other tests. The clinician can, at the end, score the level and the severity of dry eye with a classification in 5 level steps. So let's have a look at the rationale of the dry eye report. So the rationale is, we can explain the rationale if you look at, if you move back to the TIFOS diagram, in which we we can see, for example, that it's important to check the symptomatology, and that's the reason why they put the OSD inside, but also the tear film stability. And this can be done through the non-invasive breakup time, but also osmolarity, and we can report what we measure with other instruments for osmolarity. Also, we can check the ocular redness, so the state, the health of the ocular surface, and also the tear meniscus. That is what is very important to measure the amount, the volume of tear, and also the meibomian gland assessment that can perform to check if the problem is evaporative or not. So is it linked to lipid or not? Clearly, all these tests, so the question is for all these tests, are they reliable? Are they accurate? Are they, in terms of repeatability, are they good or not? Clearly, they are new. Some of those are new. So sometimes we don't have information. That's the reason why 1 year ago, roughly 1 year ago, we started at COMIT, and these are the my colleague at COMIP, so that the center in University of Milano Bicocca, where we are started forming different experiment, different study. So we are carrying on in progress a lot of study on tear film. So I would like to share with you just a couple of these studies. One is on tear meniscus aid, and the other one on non-invasive breakup time. So let's start with the tear meniscus aid study. So what we are doing now and what we did in the past. This is a paper. So let's have a look before to show you some data. I would like to show you a little bit about tear meniscus aid assessment. As I told you before, this is a device that allows us in the dry eye report system to measure the age of the tear meniscus that is on the lower lid, and we can measure in different point with a system, with a rule, basically with a ruler, the age of the tear meniscus. As the TFOS stated, the tear meniscus aid is the most direct approach to study the tear film volume, and the normality for the tear meniscus aid is roughly 0.2, 0.3 millimeters, and dry eye is usually something that is below 0.2. But these are data from slit lamp tear meniscus aid measurement. So what about, for example, different system like, for example, the dry eye report? But before this, the question is this kind of measurements reliable, for example? And that's exactly what we studied. So we try to analyze the inter-observer reliability in the margin lower tear meniscus aids through this new system of acquisition, so the dry eye report. So what we did, we took a pool of images that we already acquired and stored in our database in the clinics. And so we enrolled 4 observers, recently graduated in optometry, and 2 optometrists with more than 20 years of clinical experience. And we asked them to measure the tear meniscus aid in 3 different positions on the lower tear meniscus, one central here. They were able to do that, overlapped on the screen, basically a transparent, semi-transparent sheet in which they could check, for example, the position, the first position, the second position, 30 degrees nasally or temporally, depending on the eye, and the other one on the 30 degrees on the other side. And they have to measure in 3 different positions the tear meniscus aid in this way. Okay, so let's have a look very quickly at the result in terms of inter-observer reliability. And here we see what we call juniors. So we have 2 people, junior people, so just graduated, and 2 senior people. And we'll look here the average and standard deviation of the measurements of the 4 people here in the central position of the tear meniscus aid for the right eye, for the left eye, or the nasal position for the right and left, and temporal, and so on. So as we can see here, and maybe you can maybe detect from the data, it seems that there is, not seems, but there is a significant difference between the measurement. But if you see the number here, the clinical difference between the people, the observers, is not so much. And if you look at it, ICC, so the intraocular correction coefficient, they are very good. They are pretty good. So it seems that there is not a big difference in terms of clinical difference in measuring the tear meniscus, as well as the reliability in terms of the ICC is very good. What about the intra-observer reliability? In other words, if I perform twice the measurements with a 15 days of delay, what happens? So these are in this graph, you see the first measure, the test, and the retest. And as you can see here, the graphs and the bars are very, very similar. So although some of those are significant, but once again, the clinical significance of the data seems very, very low. So the clinical significance is negligible compared to the statistical difference. Once again, we measure the intra-class correction coefficient, and we can see the intra-class correction coefficient can allow us to state that the intra-observer reliability of the tear meniscus measurements seems very good. So, for example, just to conclude for this kind of study, so the inter-observer reliability in assessing the tear meniscus by the dry eye report appeared very good in terms of ICCs, either centrally, nasally, or temporally. Also, the inter-observer reliability appears extremely good too. But another point that I didn't stress maybe in the last slides is the more experienced clinicians did not show better ICC values. So this means that if you put, for example, a young graduate, for example, a physician or an optometrist, technicians, maybe the measurements could be very, very good as well. Okay, let's move on the other topics. So the non-invasive brachial time, that is very interesting. Maybe is the most studied test for dry assessment ever, and we have mountains. We have thousands of papers on this argument. But let's have a look how it works. So in the dry eye report, it works in this way. So we have a placido disc technology. We projected a placido disc on the cornea, we know very well, and we measure the interval of time that elapses between a complete blink and the appearance of the first break in the tear film. Clearly, the first break is detected by a distortion in the circles here of the placido disc. Generally, the time with a non-invasive brachial time is longer than fluorescent brachial time. So the invasive brachial time, the classical brachial time. And as we can see in a while, our data demonstrated also this point. So we got the same data. So these are the data for normal population, LT population from Nichols, and clearly, the advantage of a system like that is that we can automatically assess in the keratoscopic image the break. So the system allows us to do that automatically. Let's have a look at an example of this. For example, here we have the reflection of the placido disc on the cornea, and the system is measuring automatically first break that should appear here, roughly here. And the system provide us, the software provide us also a backup time map that we could not measure before this kind of softwares. And so we can have different markers of the breaks. But what about the agreement, for example, of this system with other systems? What about the agreement between the automatic and manual measurements? These are the questions that arise us in our group, and we started to try to reply to this to answer to this question. For example, in this first study, we analyzed the agreement and repeatability of 3 non-invasive breakup time measurements. The first study is on 30 subjects, pretty normal in terms of tear film, but very young, so they are students basically. We use the Polaris from CSO, the Easy Tears from Easy Tear, and the dry report using a keratoscope device. These are the devices that we use in a random order, and because the fluorescein breakup time is invasive, we left the fluorescein breakup time at the end, while these three non-invasive breakup time were randomly assessed at the beginning. After 2 hours of difference, we repeated in a further session on the same day these kind of measurements. So let's have a look at the results. I will show just one eye because clearly the eyes are associated. We didn't pull together for a statistical reason that we know very well. So I'm providing here just the left eye data. And what about the data? Here we have the fluorescein breakup time. Here we have the dry eye report. And as we know from literature, usually non-invasive breakup time assessment give us a longer time. And that's exactly what we found as well. But we found a difference between them. So in other words, these systems are not equal, especially if we make a comparison. You will see that the non-invasive breakup time are different from fluorescein breakup time, but also this one is different from this, for example. So there are different instruments bring us different results. What about the test-retest reliability? So the repeatability of the test. Here we see that, for example, not so much difference there is between the test and retest. So we measure again the interclass correlation coefficient. We measure more than this, but I'm showing just these coefficients, and they are pretty good, especially the non-invasive tests are pretty good. Also the dry report. Instead, the fluorescein breakup time is pretty bad in terms of reliability. So conclude the second study that I'm showing you. So breakup time measure with fluorescein result is significantly shortened compared to all non-invasive breakup time procedures. Non-invasive breakup time devices appear performing very similarly with the dry eyes report, resulting in a slightly longer BOT respect to other non-invasive breakup devices. So it's a little bit longer. That's our result. And repeatability resulted better for non-invasive breakup time procedure, all of those, than fluorescein breakup time. So just to finish, I want to show you the last experiment that we performed in our lab. And once again, we were very interested in the algorithm. Is the algorithm of the dry eye report accurate or not? So if I perform with the algorithm and if I measure manually, is there a difference? So we took 95 videos, quite good videos in terms of quality of video quality, previously recorded in our database. And we asked again to one junior, let's say junior assessor or observer and one senior assessor. And we asked to them to assess the video and measure the breakup time in a random order twice, but I'm presenting you just the results between the manual and automatic assessment. So this is the what we asked. So we use another software, not the dry eye report software, because you can see the results. So we exported all the video in another software, and we showed the experimenter, the observer, the videos. So these are the correlation between, for example, automatic non-invasive breakup time and manual non-invasive breakup time. They're pretty good. So both either for junior or senior observers. So they are pretty good in terms of coefficient or correlation coefficient, and correlation coefficient of determination. So they are very good. But if we see at the measure at the distribution, we see that there was a significant difference between the automatic assessment of non-invasive breakup time and the manual assessment. So just to conclude, there was a strong correlation between automatic and manual non-invasive breakup time, but a significant difference between the average non-invasive breakup time was found depending by the observer. So we have to take notes to bear in mind that this is what happened with a different instrument. Again, different instrument give us different results. So general conclusion, and I think I'm in the time, so just for some question. So the dry disease is a big unsolved issue. So more than 300 million people worldwide are affected. Clearly, we need a clever and quick set of battery of tests, so a battery of tests that can be clinically performable, and maybe they are better if they're non-invasive, if they are automatic. So we should try to enhance the. So this is not the end. This is the beginning, maybe. So we are proceeding in enhancing the tear film assessment. But this is the way. So non-invasive tests, automatic tests that look at different aspects of tear film. The report is something that can be useful because it provides us some of those enhancement solution that I highlighted here. But also with this some preliminary data that I show from our lab, we are observing that different, techniques, different instruments bring us different results. So be careful. So dry eye report is good, but we have to reason to things in a different way. And because if we compare that data with the old data that we have from fluorescent breakup time or other tests, maybe we have different results. I think that's it. And so it's a little bit is in the puzzle of dry eye assessment that I put here. So thank you for your attention. And the time, I think, is good.
Thank you so much, Fabrizio. That was very comprehensive, and you are dealing with a very, very tough subject, and it's really important and very common that we see patients with dry eye and we don't know what to do. Now, at least we know what we can do. We have a couple of questions, and I'll go with the first question, Fabrizio. Can you elaborate a little bit more on how we do the non-invasive breakup time test and what kind of keratoscope is being used in this test?
Okay, so if I understood correctly, you're asking about the kind of keratoscope, right?
Yes.
Okay, clearly, if you look, for example, at the result of the 3 tests that I showed you before, so the 3 different non-invasive breakup time, one aspect that raised to our attention, that arise to our attention, is the fact that they gave us different results. So why? So clearly, there are some aspects. The keratoscope, I think, is one of the most important because, for example, the size of the keratoscope, but also the luminance of the keratoscope can affect the time. For example, if you put more light, clearly you can induce more tearing, and that can affect, but also the size. If you look at non-invasive breakup time with a very small Placido disc, clearly you are observing just a small part of cornea or the corneal surface. So you have to look at a wide part. Also, the size of the rings are affecting because you can detect the break depending on the size of the ring as well.
Excellent. Excellent. Thank you. We have time for one more question, and I can see one question coming here in the question and answer box. Yeah. It says, can the non-invasive breakup time be performed on a contact lens? And what kind of information can we achieve performing this type of measurement?
Okay. Clearly, you can. The answer is you can perform non-invasive breakup time on the contact lens surface, but it provides us a very different information. So, for example, you're not measuring the tear film, but you're measuring the pre-lens tear film. That is basically, it's completely different. So, for example, there is no mucin layer on the tear film, on the pre-lens tear film. So you're measuring something that is thinner, that's maybe few microns, 2-3 microns compared to 7-8 microns of the normal tear film. And also, maybe you are measuring something that is linked to the material of contact lenses. In fact, this kind of test is performing to assess the wearability in vivo of contact lenses. This is one of the way we can assess the wearability of a specific material in vivo, not in vitro. So I think it's something different, but we can perform, and we do actually in clinical practice and also in research labs.
Excellent, Fabrizio. And then we have one more question, but I think it referred to the same thing. It says, hi Fabrizio, did you perform dry eye test with HI contact lenses in the eye, with the contact lenses in the eye?
I think it's the same. I think it's the same. We do, but for different reason. Yeah, we do, but for different reason, not for the dry assessment.
Okay. Thank you, Fabrizio, very much.
Thanks a lot.
That was a great presentation. And then we're going to move to our next talk by Dr. Professor Rohit Chetty from Bangalore, India. Rohit is going to tackle the topic of MS39, a new hybrid workstation for the new normal. Dr. Chetty is a professor at Sri Devaraj Medical College in Bangalore, India, and he's the vice chairman of Narayana Nitharalaya Eye Institute. I hope I'm saying it properly.
Perfect, Dr. Ella. Thank you, and thanks the CSO for this opportunity. These are my financial disclosure. I have nothing specific to talk today. These are COVID times. I'm sure a lot of you are worried about many things, aerosols, and when you're going back to your practice. So one of the major issues is when you're using multiple tools is always about contamination. How these aerosols or droplets contaminate your tools. And as refractive cataract surgeons, we are now forced to use multiple tools for different things, from epithelial mapping to topographies and everything. So my talk is, in this new normal, when we go into this new dimension, how do we use one instead of all these things which has been done? That's my talk today. This is a topography based Placido disc and OCT-based diagnostics, which is a combination of two. So it gives you the whole eye measurement, both the refractive power. There's a base mix of Placido and OCT. And like all other topographers of modern day, it looks at the elevation, curvatures, and all these maps. So what are the new features it has? Of course, you can look at the select imaging, which I think Emilio did show. All these factors which we have seen, the anterior chamber, the stromal measurements, what the topographies can do, refractive planning, keratoconus screening, and all this wavefront analysis, and multiple things I will discuss as I keep moving. It also has a lens biometry. It uses a ray tracing principle. And of course, like any OCT, it also comes with the glaucoma analysis and pupillometry. And the dry eye was just discussed now, so I'm not going to go into that at this point of time. The way I'm going to discuss is, I'm going to touch upon what is new, what's the true picture, the real truth, and the summary. So this is the way I'm going to run through this maps. So the maps are quite straightforward. You have a corneal thickness map, you have an anterior curvature map, anterior elevation map. This is important. What it does is, this is your epithelium. It removes the epithelium, and this is without the epithelium. The stromal changes what you get. So this is something very, very useful, and I have some cases as we move on. And you can use different averaging of your scans based on what kind of imaging you want. And this is a screenshot you get, multiple patterns. Like I said, this is an epithelial maps, and you can see your anti-elevation, the stromal elevation. So this is with the epithelium, this is without the epithelium. So how does it measure? Again, uses the OCT for the measurement, and And what's interesting is you have close to a 9mm zone epithelium mapping which it gets. So when you have a 9mm bigger zone, so you have a good amount of data which gets covered. And this is a very interesting picture. We can see that this is your Bowman's, and you can see how irregular the Bowman's is. This is post refractive surgery, and you can even look at how fine this imaging are with your in terms of Bowman's. And if you just try to, you have a nice tool which gives you a place to enlarge it. So you can actually enlarge it. You can place your cursor and you can actually enlarge this, and each image pixel you can try to see what is really happening. So there are a lot of fine, nice, unique features out here. This is a picture which is shot by a wildlife photographer 200 kilometers from where I come from, and people who are used to seeing the Jungle Book will know this picture. It's a very, very rare picture of the black cat or the black panther. We call it Bagheera in the Jungle Book. So what are the unique features of this? This is a map which is quite unique. There's a new software. You have your anterior and posterior surface. There's a new map called as a Gaussian posterior elevation. It's a mathematical derivation of a different, of like your tangential and sagittal. They use the Gaussian curvature maps, and your posterior elevation versus normal, the epithelial thickness, the stromal thickness, and from the deviation. Basically, a lot of new features are there, and of course, a lot of new indices out here, which we'll discuss as we move on. And this is your keratoconus maps, these epithelium, the elevations and posterior elevations, and it also gives you. It's very interesting is earlier it was only with the pentacam, now also has an ABCD map, and the partial thickness changes map from the center to the 6mm zone. So many things have been loaded into this system. So this is for us to use. So people are used to, so say a pentacam or a cirrus, you have mix of both of them out here. And this is something very interesting is this map, which I'm going to discuss in the next slide. What it means is red on red, or this is your red circle out here, and there are a lot of indices out here. For example, thinnest epithelial thickness, the stromal thickness, the thickness minimal, and all your curvature maps. These are all the points which you see here. If it falls inside the red circle, that means that you are going to have a suspicious of keratoconus, because if you fall in a normal thing, it has to fall outside here, not in the red circle here. So it's very, very intuitive and a very nice way of looking at all your risk factors. Where do they actually fall? Do they fall in the center, or do they fall really outside? So this is something very new, and this is just a magnified view of what it looks like. And you can see that this is the elevation. This is an anterior elevation that includes the epithelium also. With the epithelium, this is anti-stromal elevation minus the epithelium. That's something which is very unique. And you have a Zernicke analysis maps out here, which also gives you a total order aberrations, the posterior and anterior. If you combine it with the Pyramus or an Osiris-T, which is an aberrometry, then you probably get a complete aberrations of the complete profile. We published some work on epithelial Zernicke. That was very interesting concept. What we thought was that having an epithelial Zernicke helps in understanding the aberrations of your epithelial maps. So very interesting concept here is that they have an epithelial Zernicke plus your corneal Zernicke. So you have both of it together. Most of the time, we are only used to seeing this and not this, but you have both, so you can actually compare. And this is how this is an epithelial Zernicke map. That means that your comas and higher order, lower order aberrations all can be derived from the epithelium. This is from the epithelium, and you can see in keratoconus it's quite noisy compared to the normal out here. So that's something very, very exciting, because tomorrow you're looking at an early changes or a subtle changes, you can probably even see what is happening from first or for refractive screening. What's the true picture? The question always asked is this in FFKC? The true picture always is measured from the epithelium. But what we really need is we should be measuring from the Bowman's or the stromal surface. But most of the current day topographies do not do that. So because there is inherent limitation to dissociate the epithelium and the stromal surface, we published some work on, we did a mathematical correlation of how do you do, we call it as a Bowman's topography, where we virtually dissociated the epithelium from the stroma, and we were able to create an epithelial, create a stromal topography. And this is something which we've been working on. We are quite excited about this concept. With this MS39, for example, if you're looking at your epithelial thickness here, and you can see that this curvature is not right on the tangentials anterior. But if we correlate with this, there is a lot of thickening out here, but this is related. So your tangential curvature includes the epithelial maps. But if you virtually dissociate it, the blue-greens are normal, it is normal. So there is no actual elevation. But when you have an epithelium, anterior elevation is with epithelium, the stromal elevation is without. So when you have without, it's normal, with epithelium is abnormal. That is because your epithelium is irregular. So that just at one look, you know that your whole cornea, which looks irregular here, is actually a very regular surface at the stromal level. This is your stromal level. And what you're interested is at the stroma. We're not interested at the epithelium, because epithelium is just a masking agent. So this is very important, because many times in your new normal, we are always suspicious. If you can't match two machines imaging, it becomes very suspicious about what's happening. And this is what I explained. And I also explained about this this whole maps about how this indices can really help you in understanding the new parameters. So let's look at some cases. This is a patient who had a small change out here, and I was not really sure. The pentacam was a little suspicious. Now you look at this, the epithelium is irregular out here, and the stromal elevation is normal, and the posterior elevation not much of a change. So this change out here, what you're seeing, is actually related to the epithelium. So at one look at it, you know the epithelium is the problem. So this is a patient again with a small change out here, and you can see that from this map, you can see that the epithelium is irregular, the stroma is normal, the posterior surface is normal. This is actually a normal topography. But if you're using only one map, then this is abnormal. So you'll not be interested to do anything. So it really helps us to understand this topography in a much better fashion. For example, let's look at this. This is a scan of a keratoconus. You can see that epithelium is thinned out here, but that is a stromal elevation, huge elevation, matches to the posterior elevation. So the epithelium is thin, stromal, this is KC. So what happens is it helps us to understand what is really happening, and you can see in this map, all your points are inside your red area. So this is a very important feature, very important software point, which helps us to look at what is happening. So how do we apply this in keratoconus? Of course, the epithelial maps is one big areas of change. We can see that this is different types of mapping out here for the epithelium. This is a progressive case. And you can see that we are not only looking at just the anterior maps or curvature maps, we are also looking at the stromal changes. Here, the stromal elevation was 39. Now it's 49 to 57, though it's a true progression. So it is really progressing. So you're looking at it from the stromal level instead of from the epithelium. Now look at this. There is a huge amount of progression. Now, is it really a progression? No. Look at this. This was this around 6 months. The epithelium has become thick. because of the epithelium has become thicker, this is actually showing it as a elevation. And now look at what does happen. The stroma is exactly the same. This is a fantastic case. There is no stromal elevation. The epithelium has become thick because of remodeling. Many times you reduce the inflammation. This area which was thinner has become thicker, and this thicker epithelium actually shows it as a elevation or your curvature changes. So these are all very, very important things, because otherwise many times we would have done a cross-linking or repeat cross-linking, or many times we end up in a lot of problems because we have not understood the disease. So the disease of keratoconus has to be looked from the stromal point only, but not at the epithelium. But we have to dissociate the epithelium to understand what is happening at the stroma. So look at this, all the elevation maps are exactly the same. So at one look, you know, is it a true progression or a pseudo progression? Exactly the same thing here. There is a small change of progression on the pentacam, but the epithelium is again showing hypertrophy and no change at all. It's exactly the same. Even though the pentacam is showing as an elevation, but the stroma is perfectly normal. So keratoconus will have a new understanding once we start using it, because we are always used to seeing the progression from an anterior surface which is covered with epithelium, and epithelium masks, unmasks everything. So we have to now seriously start looking at keratoconus from a stromal surface, because keratoconus is not an epithelial disease, it's a stromal disease. So if you have a stromal disease, you have to look at the stroma, and this is the only time we are able to look at it from a stromal change. So all these maps are all trying to tell you that stroma is the focus of our work. So what is the true picture? You have an epithelial map, you have a stromal elevation, and you have to mix both of them to see if it's a real change or not, and the type of epithelium, how it is remodeling, how it's changing. It really helps to look at intact planning. This is a work done by me and my colleague, Dr. Sharon. We looked at different rings. This is a freely accessible thing, accessible on Indian Journal of Ophthalmology. We have an ICRS summary. It tells you based on, there's a nice uh, nice place where you can enter all your data in, and it'll tell you what type of ring you want to put. But what is interesting for me is it's based on coma. You can choose based on the coma axis. You can choose based on the topography axis. You can choose the choma axis, and you can see that the coma axis is 166 and incision axis, if a topography, is 156. So coma is what we are trying to treat. If it's a significant coma, you can even choose it on that, and you can enter it into your machine, and that's what gets feeded up. That's what gets treated. Phakic lens planning for people using phakic lens, of course, from all that's other things which we have. There's a huge amount of data we get. The important ones are the keratometry, thickness, the anterior chamber depth is very important. The white to white is very important. The lens rise is very important, because there are times when you have a high lens rise, then you always are looking out for all these factors when you're doing your procedures, and these things can be fed into the your calculators and and order the lenses. Post-what vault is what is important. You can see that it's a beautiful ICL. It can help to look at your angles properly. The ACDs, what I mentioned already, and if there's any changes of your lens vault. The few cases which I want to share with you is again Bagheera paping. I call it as the hidden mysteries. This is one case. A 45-year-old male had come to us complaining of glare. This is his topography in the right and the left eye. You can see that there is a change, and this glare and halos and all started recently. But when you look at the topography, you know that there is a significant amount of elevation out there. And when you look at the maps, you can see that this maps has epithelial change. And we were worried this epithelial changes could be related to an anterior elevation, but there is an anterior elevation out there which corresponds to the area of area of change, which is expected. So it looks like a keratoconus, but what's interesting is keratoconus usually should have happened longer. He's 45 years old, and you can't expect him to develop keratoconus suddenly. But his stromal elevation was very minimal, very, very minimal. You can just see a small elevation there, and compared to the significant amount of epithelial changes. We did a confocal microscopy, and what was interesting here is we found a small microneuroma. We have worked a lot on microneuromas. They are part of the nerve. Some patients have this neuropathic pains, and some patients have microneuromas, but they don't have pain. And these microneuroma exactly coincided with where the epithelial changes were. That could be some irritation, chronic changes, and we had to keep him on steroids and we even started him on autologous serum to see if it reduces. He's symptomatically better, but I'm not saying that it's completely gone. So all these things would have happened only because we were able to dissociate all this very well. It helps us to look at the Bowman's very well. This is a paper which we published about the Bowman's micro distortions, and we used different OCT then. We used a Leica OCT biopterin, and this is how it distorts your images. And very interestingly, you can see that there are a lot of images, refractive surgeries here, and some have wrinkles, some absolutely nothing. You can see some have wrinkles, and all this, if you enlarge the image, you can see those wrinkles out here beautifully. And these images, these wrinkles have a huge impact on your quality of vision. And this explains how your vision can get distorted by this. A few things about the changes between epithelium and the nerve morphology. We combined the confocal microscopy and in a lot of patients, and we believe that the nerves and epithelium have a very beautiful hemostasis. This is some of the patients who have got good nerves to poor nerves, and these are poor, and you can see how their epithelium is. So what I'm trying to say is the epithelium has a huge links to how your nerves are. And if you can see that this is a good one, and you can see this is a poor one. So your ocular surface disease has a huge impact on your quality of nerves. And if you do any surgery on it, in this case, you may have done a LASIK or a SMILE, you can see that the healing is completely different. The poor nerves have a poor healing, the good nerves have a good healing. So this is something very important, and this is something which we've been trying to study using this. And when you have a very poor epithelium, your quality of vision also drops. So poor nerves, poor epithelial healing, and the poor quality of vision, this is not always related to your surgeries, but is related to this. So how do we optimize this new tool? There's a, if you combine your aberrations profiling, and if you mix it with your pyramids, there's a good chance that you can use it for your MRIs. And the good thing about Schwind is that it is highly programmable. You can build in a lot of your own aberrations map. You can use a lot of select, deselect maps, and this can be used through your understanding of your topographies. To sum up, it's a mix. It's a fantastic combination of one tool, one machine which can do multiple things. Stromal mapping probably is one of the way to go because it helps to look up early screening of early diseases. Epithelium is a very nice fitting dress. It can hide everything, all your imperfections. We don't want anything to be hidden, nor we want anything to be enhanced. We just want something to be the true picture. And stromal mapping is the real true picture. Aberrations study from different direction, whether you study an epithelium or you use your pyramids to look at, or Osiris to look at your total aberration. I think the way to go. And Schwind already uses the pyramids and a lot of these aberrations, which helps us to get into a perfect system. And OCT, one good thing is that your outcome measures are not only looked from your anterior corneal surface anymore. Your outcome measures are looked at it from every layer. And this is something which is very exciting for me from an optical point of view, because I just am very excited about optics, because you look at optics from the epithelium and you know what is the status, because you can do Zernike, you can do the other mapping. You look at the Bowman's layer, I don't think any topography today gives you the Bowman's layer changes. And if you're looking at the Bowman's layer changes and you're looking at how it works, and then you're correlating, it's way forward. Then you look at your stroma, and then you go down to your changes. I thank the CSO team and everybody here, everybody from the organization to make this wonderful tool for a refractive surgeon. Thank you.
Thank you, Professor Shetty. That was wonderful, very impressive cases. And there is a question coming here for you from the audience in the Q&A box from Nita Shah. It says, Dr. Rohit, would the change in astigmatism or vision also help in suspecting progression when it is masked?
If I understood the question correctly, she's talking about the epithelium. See, if the epithelial irregularity is very high, then there is definitely a chance that it may be creating an astigmatism-like picture. So that is what I said. You look at your topography now also from your stromal surface. Like the cases I showed you, the two patients had a definite progression on your topography. But when you look at it from the epithelium and the stromal mapping, there was no progression. It was just that epithelium has become thicker or it had changed. And your stromal thickness did not actually show any change. If the stroma does not show changes, there is no progression. It's as simple as that.
So this may lead to another question. In your routine screening work for patients for refractive surgery, what is the weight you're giving to the epithelial map as opposed to the posterior elevation or the anterior elevation?
I mean, both of them have a different role in your practice, but I believe that the epithelial map is very important. Not all patients come to you with very thinning of your area where there's an elevation, but I do give a lot of importance now to the stromal mapping, because ultimately it's a stroma which is going to be telling you whether it is going to be a weaker or a stronger cornea. I'm not saying that this is going to replace everything, but it's going to add value to your refractive practice in trying to judge and plan what you want to do for your patients.
Yeah, very interesting. Okay, Rohit, thank you so much. That was very impressive. And now we are going to go to the last presentation, which I'm going to present. So I need to share my screen here. Okay, now in my talk, it's actually a very short talk, and I'm going to share with you my experience using the MS-39 over the last, I would say, 3 years or so. I'll give you a little bit of background. I started using topographies in the early 90s, actually in the late 80s, with the very first TMS topography modulation system that was available at that time. And that was a placebo-based. And then we went through all the advances with the scanning slit and the Scheimpflug. The Scheimpflug was a great improvement many years back. But I always had the dream to have a combination with between the OCT, because we know how the OCT is much more accurate than Scheimpflug imaging. And we learned over the years that the placebo technology, when it became very mature, it has no competitor. I mean, with the placebo imaging, you can actually see all the small details, the subtle details on the cornea that you might not see it with the other technology. So when the CSO came with the combination of placebo and OCT imaging, for me, this was really a dream that came true. These are my financial disclosures. I'm consulting for CSO, Star Surgical, Physiol, and Nidec. And being very much involved in refractive surgery over the last 30 years or so, maybe the main thing I want as a refractive surgeon from an anterior segment imaging device is to exclude those patients who have a high risk of ectasia. These include the moderate and advanced keratoconus, and this do not represent a clinical challenge. You can diagnose it easily with any kind of technology available. But more important are those patients with early or very early keratoconus, and even more challenging are those patients who we call keratoconus suspect. I know there is no consensus on the definition of keratoconus suspect, but at least for the sake of this presentation, let's agree that keratoconus suspects are those patients who have no signs of keratoconus, no topographic signs of keratoconus, but they have a little bit of deviation from normal. So we are afraid as surgeons, if we do refractive surgery on these patients, they might develop keratoconus later on. So this is the main thing I want from an anterior segment imaging device. Now, when we look at the cornea of a patient before refractive surgery, someone who is seeking refractive surgery, there are 4 things that I always look at. I'm not saying which is more important, but the 4 components of the examination are very important. The anterior surface of the cornea, the posterior surface of the cornea, the corneal thickness, and the epithelial thickness. And having these 4 components together in one map and measured with one device is definitely a big advantage. We can also have other maps from the MS-39, like the sagittal map, the Gaussian anterior curvature, which is relatively a new map, and it actually shows the true curvature of the cornea, and I think this map will become more and more important in the future. Anterior elevation, the tangential posterior curvature, which is sometimes overlooked by many surgeons, and I found this map very helpful in many cases to point out to the very early cases of keratoconus. And I always want to look at the keratoscopy image so I can see I can assess the validity of the examination. So you need to have a good coverage of the placido rings in order to for the map to be reliable. And we also have the keratoconus screening, which actually shows the 4 things that I just mentioned: the anterior surface, the posterior surface, the epithelium, and the corneal thickness, and also the stromal thickness, which, as we heard in the previous presentation, is the subtraction of the epithelial thickness from the corneal thickness. It gives you the stromal map, which is also important. Having a high resolution anterior segment OCT also gives you the bigger image of the anterior segment till the anterior surface of the lens, and you can even also reach the posterior capsule of the lens if you focus the device on the little bit more deeper. So it gives you a very good image of the anterior segment, including the cornea, the angle, the scleral spur, the iris pattern, and the anterior surface of the lens. And you see all the details of the cornea. And as I'm going to show you in a few minutes, preoperative and post-operative, post-laser refractive surgery you can know the depth of the thickness of the remaining stromal if you're planning an enhancement. You can see the Bowman's layer, you can see the endothelial endosmer membrane. And with this anamorphic image of the cornea, which is something really new, but very helpful, you can see in details the epithelium, the Bowman's layer, and also the back surface of the cornea. And you can detect any early asymmetry on the back surface of the cornea, like in this case. Now, this is a map of a typical keratoconus patient. So if you have a typical keratoconus, what are you going to see? You're going to have focal anterior steepening on the anterior map. You're going to have the same thing on the back surface of the cornea, a posterior elevation, which is very clear. And this is a moderate or even an advanced cone. The corneal thickness will show thinning at the area of the steepening and the posterior elevation. And you will have thinning of the epithelium on the epithelial map. Now, this is a clear keratoconus patient. This does not represent any clinical challenge. But more important is to look at those cases where you have discrepancy between different maps. So in some cases, you have changes on the anterior map. In other cases, changes on the back surface of the cornea or the epithelium. So I'll give you some examples. Some surgeons rely only, or at least mainly, on the back surface of the cornea. And I would say the keratoconus starts posteriorly, and if the back surface of the cornea is normal, so this is not a keratoconus, but it could be some dryness or irregularity of the epithelium and so on. Now, this is a patient that I saw recently, and you can see here the back surface is perfectly normal. The corneal thickness is normal, the epithelial thickness is normal, but there is this little bit of asymmetry on the anterior surface of the cornea shown on the tangential map. This kind of sagging bow tie, and again through astigmatism with sagging bow tie. It can be debatable, and some people would say, well, this is not really a keratoconus because the back surface is absolutely normal. Now, I'm going to show you the other eye of the same patient. This is a clear keratoconus shown on every single map. So this patient had early keratoconus, but it was only detected or first detected on the anterior surface of the cornea. Another case, little bit of irregularity, asymmetry on the anterior surface of the cornea. The back surface is pretty normal, corneal thickness and the epithelium is normal, but the other eye of the same patient showed a clear keratoconus. So again, this is another case where the keratoconus was detected. I'm not saying the keratoconus started on the anterior surface of the cornea, but I'm saying the keratoconus was first detected on the anterior surface of the cornea. A third case with a central truncated bow tie on the tangential anterior map, and the posterior map shows a little bit of suspicion, but it's much more clearer on the anterior surface of the cornea. The epithelium and the corneal thickness were pretty normal. The other eye of the same patient showed a very advanced keratoconus, as you see on this map. So from the previous cases, the conclusion is the anterior surface detection is very important in early detection of keratoconus, and the best way to analyze or the best way to detect the early changes on the anterior surface is the Placido technology. But you have to use the right map and the right steps and the right color scale. I don't like to use the absolute scale because it masks a lot of information. So I always recommend using the adjustable scale with a middle value of 43 at a half diopter step. This will unmask many of the changes that could be easily overseen if you are using the absolute scale. Now, the posterior surface of the cornea how important it is, it's again very important. And in many cases, the keratoconus is first detected on the back surface of the cornea. Like in this case, the epithelial map is absolutely normal, and the back surface of the cornea is clearly suspicious. And this patient had a keratoconus, but was first detected on the back surface of the cornea. Another case where the epithelium actually doesn't show any changes, but the back surface of the cornea is clearly suspicious, and you cannot ignore these changes. Now, so it's not the anterior surface or the posterior surface. It's actually the anterior surface and the posterior surface that must be used in order to select your cases and to exclude those patients with early changes. Now, we've been using Scheimpflug for so many years, and that's a very good technology, but that would be good for the last decade. Is the posterior map with the Scheimpflug the same as with OCT? Actually, the answer is not. This case, for example, on the Scheimpflug is very suspicious. The same eye on the same day on the OCT shows pretty normal posterior elevation, and this patient had LASIK actually more than 3 years ago, and he's doing very well. Now, the third thing that we look at is the thickness. And again, having the anterior segment OCT with high resolution, it gives you the accurate thickness, especially in those cases with a little bit of haze or scatter, that you can detect the early changes and more accurately than using the Scheimpflug. The most important thing in the thickness map is to look at the thickness deviation pattern, which is very important to be normal in order to do keratorefractive surgery safely. So that's one thing I always look at. Now, is the corneal thickness measurement with the Scheimpflug the same as what we are doing with the anterior segment OCT? The answer is a no. It's a big no. And I'm going to share with you this example of a patient of mine who had cross-linking. This is his corneal thickness using the Scheimpflug before cross-linking, and then 3 months after the cross-linking. And this is a difference map. So the difference map tells us that the patient had a 35 microns of thinning after cross-linking. And you're going to find this in many, or actually most of the publications on cross-linking showing thinning of the cornea after cross-linking. And this is, all of them are measured with the Scheimpflug. But if you look at the same information with the OCT, this is the same patient measured on the same day, the same eye, by the same technician, before and after cross-linking, 3 months after cross-linking, and you can see the difference in thickness is only 8 microns. So this tells you that measuring the thickness with Scheimpflug versus OCT is not the same. Now, the epithelium, there are a lot of talks about epithelium in the last few years, and I'm saying the epithelium is very important, but it's not the only important thing. So again, this is the same case I showed you before, a typical keratoconus, and you can see clearly the thinning of the epithelium at the apex of the cone. Again, this case does not represent any clinical challenge. It's an obvious keratoconus, and you can diagnose it with any kind of technology. But there are some cases, like here, for example, this is the patient. The anterior map shows kind of symmetrical, regular bow tie, no much of change on the corneal thickness except of some thinning. The posterior elevation is pretty normal, but the only positive thing is the epithelium. Epithelium shows focal thinning here, and this is something that you should not oversee. If you look at the other eye of the same patient, this patient had an obvious keratoconus on the other eye. So in this case, the first sign, the first topographic sign of keratoconus was focal thinning of the epithelium. But Is it the case in every case? And as we saw in the previous presentation, actually the answer is no. In some cases that shows a clear suspicion, like in this case, it's an early keratoconus, but the epithelium map doesn't show much of a change. Another case with a definite keratoconus shown on the back surface of the cornea, on the thickness map, on the anterior map, but the epithelium shows actually thickening at the area of the steepening. So it's not the anterior surface or the posterior surface or the thickness map or the epithelium, it's actually all of them together. It's not one or the other, it's actually one and the other. On the CSO, on the MS39, there is a set of very helpful and useful keratoconus screening indices. I know this comes from the older version of the series and the older version of the MS39, and CSO is working diligently on this to improve the keratoconus screening indices. And being part of this team who's working on this, I can tell you that the next of the new release will be much accurate and very helpful. But always remember that any keratoconus screening index is just a red flag. It raises a red flag for you saying, okay, take care. This might be a case of keratoconus, but at the end of the day, the diagnosis is the clinical diagnosis and the physician is in charge of this. So we have a set of keratoconus indices that are very helpful and that keep improving day after the day. And that are really, in my practice, I always look at them in selecting my cases for refractive surgery. So now I'm going to show you what I'm doing on everyday basis. So on a regular practice, in high volume practice, you really want to develop an algorithm where you can pick all the deviation from normal in order not to have cases with ectasia, postoperative ectasia. So what I do is, first thing, I look at the anterior surface, and here I like to look at the tangential anterior map on the adjustable scale with the 43 middle value, and then the Gaussian map. Then I look at the posterior surface, the tangential map, and the posterior elevation. And then I look at the thickness of the cornea and the epithelial thickness. Then I do the same thing for the other eye. This is a pretty normal eye, actually. And then I look at the keratoconus screening, which is very helpful. Here it shows you the anterior surface, tangential, the Gaussian, and then the deviation from normal, the deviation from normality. And the same for the posterior surface. It shows you the tangential posterior curvature, the Gaussian posterior curvature, and below here, the deviation from normality. And an important point here is that the keratoconus screening uses an aspheric toric surface with a fixed asphericity. So the anterior asphericity used here is minus 0.25, and the back surface is minus 0.3. So this tells you the difference from the normality. And the same thing for the epithelial thickness. It shows you the thickness map of a given patient and then the deviation from normality. And then the same for the stromal thickness and the corneal thickness. So in one map, you can see all the 5 important things that you want to look at. And then on your right-hand side, it gives you the different indices. And at the end, it gives you a classification, a suggested classification, whether it's normal or borderline or keratoconus, that you take in consideration. And in this box here, it gives you the high-resolution image of the cornea, of the applanated cornea, and you can see the Bowman's layer, the epithelium, the stroma in high resolution. Then I look at the same thing of the other eye, of the left eye, the keratoconus screening of the other eye. And this helps a lot in making a decision whether I'm going to go into refractive refractive surgery for this, whether LASIK or PRK or SMILE or anything. Now, another map that I really like, and this is something relatively new, that this is the enantiomorphism. Now, we know that both corneas are usually a mirror image. And you can, if you subtract the right eye from the left eye, it cannot be done because the nasal in the right eye is temporal in the left eye and vice versa. So what is done here is that you take the right eye and then the left eye and you swap the left eye and then you subtract it from the right eye. Then it gives you the difference between both eyes. In a normal patient, this difference would be very close to zero because both corneas are usually symmetrical. So if you have a patient with an early keratoconus, like in this case, you will have a big difference and you'll have asymmetry in the difference map between right and left eye. And because keratoconus is usually a bilateral disease, but usually both eyes are at different stages of the disease, so you can, this map is really helpful when it comes to keratoconus suspect cases. Having the high resolution OCT is very helpful in refractive surgery practice in post-operative evaluation of the cases. Like in this case, for example, who was planning to have enhancement, so you want to know the residual stromal thickness and the flap thickness. And this patient had a femtolasic more than 10 years ago. And you can see how nice the interface is seen here. You can measure the flap thickness and the residual corneal thickness so you can decide whether it's safe to go for an enhancement or not. This is the magnification of the same previous map. You see the interface here, you see the Bowman's membrane, and you see the epithelium. So you can really see things that we never saw with the Scheimpflug imaging before. Same with the SMILE cases, and one of the things I discovered since I started using the anterior segment OCT, that how the interface in the SMILE, post-SMILE, gives you some micro irregularity in the Bowman's layer. This is obvious in this case, and you can see this in almost every case of SMILE, and that's why the SMILE patients takes a little bit longer time for rehabilitation compared to the femtolasic. If you're doing phakic IOL screening, the Scheimpflug devices are good enough. They give you the corneal diameter, the anterior chamber depth, but with the anterior segment OCT, you can have much more information and help you for sizing of posterior chamber phakic IOL and ICL, for example, because it gives you the crystalline lens, the scleral spur to scleral spur diameter, and the angle of the anterior chamber. And post-operatively, it can help you to measure the volt, to assess the angle, and to see the position of your lens, whether it's tilted or not tilted. And these things were very difficult to see with a Scheimpflug device. So in conclusion, I do believe that a combination of the Placido and anterior segment OCT, because these are two very mature and very accurate technologies. So this combination ensures the early detection of cases of early keratoconus or keratoconus suspect through accurate analysis of the anterior surface asymmetry with the Placido technology and the posterior surface asymmetry with the OCT. Also, any thickness deviation is easily detectable with the OCT, and the epithelial thickness map is also very important to assess these cases. And I really believe that this is the way to go, and I'm pretty sure, actually, we can see many other companies are following the same path of CSO, and I'm sure in the next few years, we're going to see more and more devices combining the Placido and the OCT technology. And I thank you for your attention.
Thank you, Dr. Alla. Very good presentation of the cases, especially those keratoconus cases you showed. I have a question to you. In your practice, both as refractive and also the corneal surgeon, have you started giving this more importance than your previous topographers? Do you use this more? All refractive surgeons have their one favorite tool, which they finally base their judgment on. We all have gone through different stages. So do you think that at this point of time, this is your favorite toy where you base your judgment on?
Well, actually, the short answer is yes. Yes, since I started using the MS39, I think that this is the most valuable tool in my practice. What I'm missing with the MS39 is the entire eye aberration. So I'm actually using an aberrometer on all my cases. I'm using the MS39 on every cases. I was using a Scheimpflug device for the first 3 years since I had the MS39. And the reason I was using this is I wanted to learn and to compare the images from the Scheimpflug versus OCT. But now I'm very much convinced that the OCT replaced the Scheimpflug, and I'm not using the Scheimpflug anymore nowadays.
Absolutely agree, because more and more every day, I've also started believing that the combination makes it much, much more stronger. And in fact, we are not actually refusing sometimes cases which some patients were actually good for the surgery. See, I can understand that we have to be safe, but we also need to understand that in our endeavor to be safe, we should not be refusing something just because the machine says it's abnormal. I think we know now whether it's really an abnormality or it's a pseudo abnormality. I think that's
Absolutely.
something.
Yeah, I totally agree. I remember those days when we started using the orb scan many years back, when the orb scan became available, even before the Pentacam, and we started to rely on the posterior float, and we started to refuse many cases. And then we realized that was not correct, because that was a false positive. So with the OCT, I think we don't have the problem of false positive, and we have the ability to detect those very early cases and to understand what's happening, to understand why in the anterior surface, as the case you showed in your presentation with the epithelial thickening, but the back surface is normal, so this is a normal case, but we understand why there are some changes on certain maps, because we have everything in one device.
Absolutely. Francisco, there's a question for you. Why is it called MS39? What does MS means and what is 39 means? It's definitely not an optical word.
No, it's not optical related. MS stands for Mura Sergio. Mura Sergio is the co-founder of a CSO company, and 39 is his age of birth. And the reason why is that when we release our device, he passes away, and so that's why we decided to dedicate the device to him. So it's mostly an effective reason. So it's not definitely optical. Dr. Ala, I have a question for you. Can you please back on the case with the anterior steepening and the fellow eye of the keratoconus?
But don't ask difficult questions, Francesco.
No. I want to ask a quick. Maybe I might have an explanation, but I want to understand your point of view on this. And I also interested on the opinion of Roy and Fabrizio.
So I'm going back, and just stop me.
The very first case you said, you showed the one with the anterior steepening, and I was a fellow eye of keratoconus.
This is one. This is another one.
I think is
this one.
Yeah, let's see. It's not updating yet. So my impression was, but I asked for confirmation, that this could be a very peripheral ectasia. Okay, and as you can see, also the posterior floating rising in the inferior part, but since it's very peripheral, we cannot see in a way we are used to see keratoconic eyes, just because it's very inferior. And we also see that there is a steepening, a thickening of the epithelium just above. So this could be the hand of the donut, but the minimum is hidden. Do you think this is possible? So this kind of pattern are usually typical of very peripheral keratoconus. Do you think that?
Well, of course, yeah, of course, I understand your point, and it's well taken. There, of course, yes, the answer is it could be, but from looking at the posterior elevation in this case, I think we agree that this is kind of normal. If it's a typical peripheral keratoconus, very peripheral keratoconus, it's possible. But then look at the other eye. The keratoconus is not that peripheral. So the other eye of the same patient. So what I'm saying here is I don't think this is a very peripheral keratoconus, but it's not central. It's not a central cone, but it was more detected on the anterior surface because it's obviously, you know, the pattern. It's like pellucid-like with again true astigmatism, what we called before the lazy 8. So it's much more obvious on the back, on the anterior surface. Yes, and your point is absolutely correct. It could be if the posterior elevation can show a little bit larger map, we could detect something on the back surface of the cornea.
And usually when we have this kind of thickening of the epithelial map in this area, we can expect something just below.
Below it, yeah.
This is not the first case I see like this. So it's not easy to detect something in this case without looking at the anterior, sure, and without looking at the fellow eye. But also the posterior doesn't exactly look like a normal.
Francisco,
yeah.
There's a question for you. Do you perhaps plan to incorporate this device into any excimer laser platform? Would you like to answer this?
We love to incorporate these in platform. We are open to this kind of work. We already linked with some with the Scheimpflug laser, and we are working for this kind of connections. So.
If you can please connect this to all excimer laser platform, that would be good.
Okay, I will work hard to make this possible. I think that there are some other questions to answer. So if you can, okay, maybe the first one you already answer. So if you would replace Scheimpflug camera with the anti-receding OCT, maybe is been already answered. Yeah, the second one is the one about the platform. Yeah, this is, I think is a request from a colleague from Guatemala. If you can send some stromal segment protocol calculation. I think is mostly for Dr. Shetty.
I think he's asking for a software.
Okay. A segment protocol calculation. Okay. Yeah, let's say that soon this release will be. Actually, the software is already using the stromal mapping. If we are looking for the path deviation, we have to wait for the official release of 4.0 that only our key opinion leader are using at the moment. So it's not fully released yet, but it's a matter of days, I guess. What else?
They're asking about axial length. Why are we not adding axial length measurement in this? So that if you add an axial length, then it could be a biometer also.
Yes, this would be great. It's not so easy because the device is already very compact, but these topics is always in our mind, and so we will work hard to make this possible. I would also tell to Dr. Ala that sure we can. We were in discussion about providing you an Osiris, so you can use all our devices for the full diagnosis of the eye. But we were stopped by the COVID during our, so hopefully we can arrange this in a few time. And
yeah, sure. This would be great, to have the whole thing. There is a question here: do we have OCT plus Scheimpflug device in the future? Well, I had this question before, and I don't see a reason to have OCT combined with Scheimpflug, because I don't see anything that the Scheimpflug is doing that cannot be done with the OCT. So this question is for you, Francesco.
Yeah.
Would there be any advantage in adding Scheimpflug to an OCT?
No. Okay, let's say that if we add a Scheimpflug in OCT, the price is not going to be the same. So it's not. I don't think that this device is going to have a good market. The only real advantage, or the only field where Scheimpflug has an advantage compared to OCT, is the evaluation of opacities. Opacities, and this is also the weak point of the Scheimpflug. Opacities are a better view on a Scheimpflug system, because it's very easy to see corneal scattering on an OCT, and this is also the weak point of the Scheimpflug, because while we have scattering, we have mistakes in edge reconstruction and not reliable measurement. So this is the other face of the coin.
Yeah, absolutely. Yeah, I actually don't see any. I don't think anyone is going to go into this direction, combining OCT with Scheimpflug. And yes, as you said, scattering is the big disadvantage of the Scheimpflug imaging, and we learned this with our Scheimpflug experience with any patient who had any kind of corneal surgery, whether it's refractive surgery or cross-linking or corneal graft or anything. Then the system is totally blind. When you have scatter, you cannot see beyond it.
Yeah. I think that we have last few seconds for the question for our friend Tamer Gamali. So maybe you want to answer, Dr. Alam. Would the machine be helpful in understanding the difference between treating high astigmatism with laser using the toric ablation and cross-cylinder technique? So this is most surgical than technical.
Yeah.
So
Yeah, of course. Yes, Tamer, yes, absolutely. And we didn't have time to show all the features, but if you go on the differential map, you have two options: either compare or to subtract one map from the other. And then you can subtract preoperative versus postoperative, and then you can see the difference between the astigmatism, whether different laser platforms. I use this, I have now different laser platforms, so I'm comparing, and you can compare any techniques. If you subtract the post-op from the pre-op, then you will have a very good picture on even the ablation profile of the laser that you're using. So the last one: how do you compare the accuracy of the BAD in the Pentacam to the keratoconus screening of the Sirius and MS39?
I don't think that we have to answer to this question, because no one from the other for the competition is replying, so it's not fair to answer. So it's up to you, but you can skip the question if you like.
Well, yeah, but my answer would be, any keratoconus screening, whether on the Sirius or the MS39 or the Pentacam or the Galilei or the OPD scan or anything, would be just a helping tool to the surgeon, but none of them will ever be 100% accurate. You can never ever rely on keratoconus screening. But what I can say that with the MS39, the available keratoconus screening is very helpful, but I know that it will become much more helpful in the future, in the very near future.
Okay. I think that we are running out of time. I would like to thank you, all the attendees and all the speakers for being together with us tonight. And this is going to be probably our last meeting before the summer stop. So I would take this chance to wish you a very nice summer, and I hope to see you soon in September. Bye-bye.
Well, thank you very much.
Okay.
Thank you, everyone. Thank you for the panelists, the speakers, and the attendees, and CSO, the R&D, and everyone who made this meeting happen. It was really, I personally learned a lot, and have a happy summer and stay safe.
Thank you. Bye-bye.
Bye.